Today we'll be talking about ACL injury and reconstruction. Everybody's probably seen these cases because you're all in the field of orthopedics, and you must also understand this simple statistics. In the knee, the ACL is one of the most common serious injuries which is encountered. And when the ACL gets injured, the disability is significant. Today in 2019, we have evolved over many learning issues, over many other problems. Today, ACL reconstruction is an established technique. Now you must understand what do I mean by that, because now the results are reproducible and we can do it purely arthroscopic without any problem. And of course, in a large percentage of cases, the outcomes are very good. However, since many of you are young, you must know what is new in our knowledge. You must realize that the injury patterns and which patient will get a ACL injury with a knee damage or knee problem is not fully understood. The female athletes, it must be very clear, are different as compared to men when we talk about ACL injuries. The surgical concepts are changing, and the last 20 years they have evolved very significantly. And the best thing which has happened is that we have great improvement in graft fixation technology. This has actually allowed us so much earlier rehabilitation that the results have become that much better. And this is one of the key points. The rehabilitation protocols applicable today are perhaps one of the key factors why we get such good outcomes in sports persons with ACL injuries. I'm going to discuss this little talk on some little points which I have labeled out. The first of all is, do all cases of ACL injury need a reconstruction? That's an important thing, because we must also realize that all the injuries are not the same. The next thing which we will talk about is the timing. When should we think about reconstructing ACLs if we plan to do them? Subsequently, we have a choice of grafts which will be discussed, and the methods of reconstruction, which will include the surgical techniques, etc. And I'll show you a couple of videos to go along with it at that time. And of course, where we are today vis-a-vis methods of graft fixation, and go on to a bit about rehabilitation protocols. So let's take these points one by one. The first point, does every knee with an ACL injury need a reconstruction? Now this is something which is very important, because we have a group of patients who are called copers. The best example I quote is Yuvraj Singh, who did not get his knee ACL reconstruction done for many years, still continued to play. And these copers are the ones who can get appropriate rehab, probably use a supportive brace and go on with their sport also. You must also realize that patient demands differ. If it's a housewife who's not going to be too demanding of her knee, she can do well with a bit of not a bit, but a significant amount of exercise therapy, and with a little bit of care, she can have a normal life. You must understand, a coper is one who is living with a torn ACL. This ACL never regenerates. So it's like me using my spectacles. Nothing's improved with my eyes, but I can see well. So copers, if they use braces for the initial time, while their muscle sense, muscle tone is coming back, can do well in a large percentage of patients. Remember, they must not attempt to indulge in contact sports, because despite being a coper, a contact sport will not be tolerated by that knee. Additionally, to be a coper, you must have the secondary restraints like the posterolateral capsule, the ALL, they must be intact, and the probability of you being a coper then increases. Second point, all injuries to the knee, all injuries to the ACL are not the same. The severity of the injury is reflected by the multiligamentous injuries, and the people who have multiligamentous injuries, or you have associated posterolateral corner injury or a ALL ligament injury, which we have now discovered to be of some significance, do not do that well. They here it is not the ACL reconstruction which is important. You have to look at the overall stability of the knee, which becomes that much more important. And patients who already come to you with multiple episodes of giving way have probably damaged their secondary restraints, and they do worse despite whatever you do to them. The injury mechanism is also important. Previously, it was thought that all ACL injuries were contact injuries, whereas now we realize that non-contact injuries are much more frequent than contact injuries. But you must remember that the contact injury severity of trauma to the knee is going to be much more, whereas the non-contact injury, the severity of trauma to the knee would be much lesser. So the outcome in the second group would be that much better. Next point is timing. Should we do it immediately? Perhaps in $1 million per day sports person, they do it immediately, the football stars, the basketball stars. But most patients do not do very well if they are operated early. This is the reason, that is, they develop arthrofibrosis, which is probably due to the hemarthrosis. It's also due to the bone marrow edema, where people say the graft fixation may have a problem. So this thing has to be kept in mind about all this. Ideal time for ACL reconstruction, if you want to do it early, is when the pain settles, when the patient has gone into a rehab protocol and started doing his exercises without pain and has got a good range of movement. That is the time when you should be thinking about doing an ACL reconstruction. Too much delay also is not too good. If you leave it too long, the quadriceps wastes. And once you get a quadriceps wasting which has set in, it's difficult to bring the patient back to the same level of quadriceps strength. Therefore, they also start getting episodes of giving way. And if they have episodes of giving way, secondary restraints can get damaged. You can get meniscal injuries, you can get cartilage injuries, and all of that becomes a problem. So if you're wanting to reconstruct, it should not be delayed too long. The point number 5 is the choice of the graft. Most over India, most of Asia, we are using autografts. Most, not really most, but a large percentage of people in the US and Europe are using allografts because they are available. And for a short time, there came in the era of the synthetic or the artificial ligaments, because you would not have needed to look at grafts. So there was a huge debate about graft choice. If you choose autografts, they are the hamstrings, bone patellar tendon, and recently, which has come in vogue, is the quadriceps tendon with a bone block distally. The allografts can be anything. People have used the tibialis anterior, tendoachillis, tibialis posterior. Now recently I found out they are using the peronei. But you can also get hamstrings and BPT grafts and quadriceps tendon grafts from all over there. And the synthetic ligaments were basically of two types, the Gore-Tex and the large ligaments. Now, people recently, till about 2000 to 2010, they shifted en masse to trying to do hamstring tendons, because it was thought that hamstrings are much better and they do not have cause problems to the front of the knee. But a recent meta-analysis has shown that if you want to do ACL reconstruction in a high-end athlete who's going to use the knee a lot, you should use the bone patellar tendon, because it gets better rotational stability and it brings the patients back to a higher activity level. On the other hand, the hamstrings are good too. Firstly, they can regenerate, so that's not a problem over there. And secondly, the post-operative complications related to the front of the knee and maybe the damage to the infrapatellar branch of the saphenous nerve is that much less. So this debate is going on, and there is good evidence to support both of them. But in 2000 to 2015, the bone patellar tendon came down. One of the reasons, I think, is because people didn't want to buy those special saws or small saws. But since 2015, the bone patellar tendon is regaining its importance, and the allografts still holding true, holding good in the US and Europe, whereas the big advantage for an allograft is no morbidity, where you harvest the graft from, and you can use any type. If you want to use the BPT, or depends upon the availability. But the cost is significant, and for a while there was a significant risk of disease transmission. What about synthetic ligaments? By and large, I think they have failed. People have tried large ligament inside the joint, but they've had a huge amount of synovial reactions. So people thought that they would act like scaffolds which would allow tissue to grow into them, and they would act like a normal ACL, but not really withstood the test of time. So extra-articularly they are good, intra-articularly we are not so sure they are any good, but some degree of augmentation can be given if we do the ACL, you augment an ACL reconstruction with these synthetic ligaments. This is a chart from a recent publication by Dr. Raju Vaishya's group in Delhi, and if you look at it, the hamstring tendons were till about 1995 they were low, but then they came up. By 2014 they have again started to come down. Whereas the bone patellar tendon was initially very high up there, then it came down about 2010 and 9, but now it's picking up again. So it's now comes down to a personal choice and a particular situation. Like females don't want a scar on the front, go for a hamstring graft. A high-end rugby player or football player, maybe you should go in for a bone patellar tendon graft. I personally choose bone patellar tendon bone, and I'll show you my technique of doing it. We do it with the knee on the table. 90-degree flexion is ideal because you don't have to sit down. People sit down on the side of the table and do it also. It's not a problem, but this is how I do it. We do a central incision, slightly oblique, and we go down to the paratenon, cut the paratenon, and then start by 2 parallel incisions in the tendon, and then make sure that we have the right width, and then we extend it below and above and use a mini saw to cut into the bone, and we can take out the appropriate length. People say 10, but I don't think 10 is required. Most of the time I've never had to use more than 9, because if it's longer then it's a problem. So these things you have to decide before this thing. The key point is, if you've taken the central 1/3 of the tendon, don't try and suture the tendon back, because then it will lower the patella and you could have patellofemoral problems. The only thing you need to suture is the paratenon, and there's a chance that the central 1/3 of the patellar tendon regenerates. So this is an important point you have to realize. Then we come to the 6th point, which is the method of reconstruction. There are 2 things over here. One is, should it be a single or a double bundle reconstruction, and how do you place the tunnels? So I'll discuss them one by one. Now the double bundle concept came up with the thinking, or with the understanding, if you may say so, that the ACL has 2 functional bundles. The anteromedial bundle is tighter in flexion, and the posterolateral bundle is tighter in extension. So that means with a single graft, we probably could not restore the biomechanics as we wanted to do. I'm not so sure you can do it with a double bundle, but that was the concept which was propagated, and Freddie Few from the US was one of the top contenders who's published a hell of a lot in this thing. Now if you look at it, if we are theoretically able to reconstruct 2 bundles, we may have better biomechanics, and this has been shown to be correct in biomechanical studies in cadavers. You will actually need 2 separate grafts, so you have to make 4 tunnels. Now some people are doing a double bundle with 2 tunnels only, because they're having 2 different strands, but they're having 2 tunnels. But the real way, the best way, is to have 4 tunnels and 4 implants and 2 grafts. So that's a bit costly, and that's a bit cumbersome. So many people are going away from it, because it's becoming, it's been shown that it is not necessary that the results, the outcomes are that much better. If you look at this graph, the same graph from Dr. Vaishya's group, the double bundle actually started coming into vogue in about 2004. And Freddie Fu was the one who was selling it the most. And if you follow this graph right up till here, 2010 it was its peak, and now in 2016, 18, 19, it's come down. So the interest or the significance of the double bundle concept is phasing out a lot. People are saying double bundle is actually double trouble. And I personally, my personal view is I agree, because I don't think we will be able to get that much more improvement in ACL function by using double the amount of implants and having double the amount of graft harvesting and having 4 tunnels. Now the standard method of reconstruction, which probably is done most places in India is a single bundle technique using either the hamstrings or the bone patellar tendon, although I am aware of a few surgeons who are using the quadriceps tendon. And I'm going to be showing you the video of the bone patellar bone tendon technique. The first thing when you put in your scope is that you need to clear the area in front of the ACL. The thing which is attached in the front is actually the infrapatellar plica, some call it the ligamentum mucosum, and then you'll be able to see right over there that this area where the ACL attaches is deficient, and the ACL has actually fallen down and is attached to the PCL over here. Now you clear out that area. Nowadays we don't do very extensive notchplasty. We just clear out the soft tissues till the back of the knee, which we want to see. We make sure there's no large ridge here, which many have called the residence ridge. And I try to preserve a lot of the residual ACL stump unless it's hypertrophied and we are scared of it causing what we call as a cyclops lesion. Then we need, once we are cleared about it, we've attended to the meniscal pathology or chondral pathology which is there, then we start making a tibial tunnel. You use a tibial drill guide which is available at most companies, and you put it at an angle that the drill hole becomes at about 45 degrees to the vertical, and you insert it in line with the posterior edge of the lateral meniscus. Not so laterally, but we bring it down into the center, into the ACL footprint, and hold it over there. And the ideal tunnel position is right over there. You should not bring it too proximal or towards the front of the knee, otherwise you will damage the intermeniscus ligament. So you have to be very, very careful where you do it, and the positioning is important. If you are too anterior, the graft will start impinging in extension. If you are too posterior, the graft will impinge against the PCL in flexion. So the position of the tibial and the femoral tunnels is very, very crucial. Now you put in a guide pin after that. Once you have this tibial jig there, you put in a guide pin, and if you notice this guide pin is slightly more medial than you want it to be. That's because the point of the guide has pushed it to the medial side. But if the exit point into the tibia is correct, this can be changed. I don't want you to struggle too much at the first place trying to go it. If the exit point is correct, the direction of the tunnel can be changed. I'll tell you a little trick how we do it. The next thing which you do is use a 4.5 millimeter cannulator drill. Once you have that 4.5 millimeter cannulator drill, you have a wider canal in which you can shift your guide pin. And then you do the same thing. You shift your guide pin, and to the approximate place where you want it to be in the femur, you put it. Now you see it is lateral to the PCL, so it's not a problem. And the next step then is you can ream the tibial tunnel, taking care that you don't suddenly enter into the tibia and damage the PCL or anything else. We have various sizes of reamers. I use a 4.5 millimeter drill, and I then go in for my 9 millimeter or whatever 10 millimeter reamer, but they have to be sharp. If they are blunt, then it is wise to go with a staged reaming protocol. Once the reaming is done, you shave the tunnel. If you notice here, we still leave some of the residual ACL tissue behind. And I'll tell you why we leave that in a moment. But it's important because you want some of the nerve fibers there to be intact. Now comes the placement of the femoral guide. The offset guides which are available are placed at the back of the condyle, and through these guides you can put in a drill. You can drill in the beath pin or the guide wire at the appropriate time, and it will exit out on the anterolateral aspect of the knee. Once the guide wire is in position, then you again, at least I do it, I drill it with a 4.5 millimeter drill bit through and through to make the passage of the guide wire easier. And I have to make sure that I don't go too posteriorly, otherwise I will break the tunnel at the back, and if I'm too anterior, I will impinge the graft in extension. Now comes these Acon reamers. The trick is, do not rotate the reamer till you are touching bone, otherwise you will be you may have the chance of injuring the PCL. Go down to the desired depth that you want, 20, 25, 30, whatever you want. I add 5 millimeters, which gives me a little bit of play to pull in the graft if my graft is too long distally, and then I can use an interfering screw. And then you shave out this tunnel. This tunnel has to be cleared out properly, otherwise the soft tissues will impinge and you will have difficulties in passing your graft. Rasping when you are using bone, patellar bone, is very, very important, because you don't want any protruding bones, bone edges or bone spikes over there. So you rasp it out and you clean it out, and then subsequently you pass in the bone graft. This particular case, we've passed the bone graft with the bone anterior to the graft. If you think that you are too close to the PCL, you can reverse it, but that's a trick which we will talk later on. And the next step comes up is passing the wire for inserting the screw. For passing this wire, you have to bend the knee quite a lot, because the direction of the wire, which is coming from above the tibia, is different from the direction of the tunnel, which we have done through a tibial, through the trans-tibial technique. Once the wire is in place, you have to create a little bit of a starting point in bone patellar tendon bone for your screw, and we have what we call as a notcher. You make a little notch in the femur, and subsequently over the wire you pass in the screw. This is a green colored screw, it's a Indian screw. Most screws are white, and if the fluid becomes hazy, then you have a problem with this. But these green colored screws are easy to see and makes for a nice fixation also. Now you pass the wire for the tibial screw. This is done from outside, and this is the arthroscopic view, and the wire should preferably come anterior, because then the screw will tend to push the graft slightly back, not too much, but if you think that your tunnel is slightly anterior, by putting the screw over here from this way, you tend to push the graft back, which will minimize or avoid impingement on the roof of the condylar notch in extension. Few things about tunnel positioning are changing, not the tibial tunnel, but the femoral tunnel, and that's something which we must know. The technique I've described is known as the trans-tibial technique. Now in this way, we've made the tunnel through the tibial tunnel, and they're almost in a straight line. So sometimes you can have problems in placing the graft, in placing the screw, etc. So what most people are advocating and most people are using is known as the transportal technique. That is, they take the anteromedial portal and put the wire and the jig through that, which is independent of the tibial tunnel, and this will make the tunnels not parallel, not in a straight line, which is actually ideal. But then this is the way we do it when we do a transtibial method. It's a vertical tunnel, and the disadvantage of this is that sometimes you don't get so much rotational stability. On the other hand, when you want a more oblique tunnel, or when you get a more oblique tunnel when you do a transportal technique, you will get improved rotational stability. So most surgeons today have shifted to a transportal technique. But there's problems. When you're using your anteromedial portal for the femoral tunnels, you probably end up with shorter tunnels, and the chance of a tunnel wall blowout at the back becomes that much significant. So you sometimes need to do distant fixation, not the interference screw fixation. Now the beath pin also exits more inferiorly. It exits at a place where you could have some kind of potentially some injury to the peroneal or neurovascular structures, and you have to flex the knee. It is more flexed than even when it's actually hyperflexed. So you have difficulty in putting the femoral aiming device, and you can also have difficulty in using the reamers. These reamers will actually go on to damage or impinge against the medial condyle. So these are big problems, and that is why some companies have introduced flexible reamers which will actually not do the damage and will allow you to do a single or the best placed, most appropriately placed tunnel. Now comes the question of graft fixation. There are two methods of fixation. One is distant fixation. That means they are fixed away from the apertures, which is the ideal fixation to make sure the graft doesn't move. And then there is the interference fit fixation. Now, many things have changed. The interference screws have evolved. The endo buttons are titanium so that you can do MRIs later on. The rods and pins were metal. They have evolved into biodegradable tissues, and you have also got what we know as soft tissue washers. And the methods of fixation is that I personally use bone interference fixation because of the fact that I use BPT. But you can use rods and pins when you're using tendon grafts. Biodegradable implants are probably what are being used the most today. And they are resorbed and replaced by the host bone, and this doesn't need to give any later screw removal or any problems subsequently. It's a fact that ACL reconstruction is done well by most surgeons. There's no residual laxity, you've done a good rehabilitation. But those of you who've actually operated will find that many patients, despite a well-done ACL, are not satisfied. What happened? The issue sometimes here is something was not available in our understanding till about 10-15 years ago. What we are not understanding, that the ACL is not purely a mechanical ligament. It has proprioception also. It provides sensory inputs. So there is a sensory deficit whenever you have an ACL injury over there. And we worked on this in PGI, and we've published over time many times that proprioception is an important factor in ACL recovery and good outcomes. We were able to demonstrate even in the torn ACL, the residual ACL, that some sensory receptors still exist. So what people are doing now, at least we are doing now, is we are saving the ACL remnant. Like in this particular case, you take off the floating ACL and you leave this remnant. See, all this is left behind, and you drill your tunnels, the transtibial, femoral tunnel, and you put your guides in, and then you put your graft in like that. And at the end of it all, these residual remnants will stick to the graft, and hopefully we get some joint position cells, some pull, some better reinnervation, regeneration of the graft. So this is what most people are doing, which is a more biological way of doing an ACL reconstruction. This is called actually surgical enhancement sometimes. So the remnants with residual nerve tissues, which has been proven, will adhere to the graft, could give us a stretch reflex and other sensory inputs. It could also contribute to ingrowths of nerves and vessels into this. Lastly are the rehab methods. Have we really evolved in rehab methods? And I'd say yes. Since 1992, when I started doing the first ACL, we have evolved very, very significantly. Today, the protocols are very aggressive. They are modified from the Shelburne protocols, and what we need is immediate motion. We talk about passive full extension from day one. You talk about immediate early weight bearing. You also talk about functional exercises. And to add it all is lots and lots of ice therapy. Cryotherapy is actually one of the best things you can do for them in the post-op period. Then you also have braces, which allow them to go back to full activity very, very soon. How do we determine how well an ACL injury would do? Well, return to sports is one of the things today. But remember, even in the best of hands, it's 60 to 80%. And it also depends upon the type of sports the patient wants to go back to. A point of note is are things different with females? Yes, they are. Because female athletes have a higher chance of getting an ACL injury with the same degree of trauma, like basketball, etc. And there are various reasons to it. The Q angle is more. They have a wider pelvis, and they land differently after a jump. So when they land, when males land, they recruit the hamstrings and gastrocnemius first. So the translation to the front is not so bad. But when the females land, they recruit the quadriceps first. So the translation to the front, which is stopped by the hamstring for a millisecond or two, is not there. So that's a problem over there. So in females, we need special protocols for injury prevention as well as for rehabilitations. So the specific exercise protocols to control valgus movement and new methods to ensure muscular coordination are the key factors for female athletes. In the end, what's the single commonest fall method or cause of failure in single bundle ACL reconstruction? Today also, it is improper surgical technique. And principal amongst them is wrong tunnel placement, because even today we see cases like this where the graft is placed more anterior than posterior, and these guys are going to break anyway. So poor graft placement is a consequence of bad tunnels, and that's why improper surgical techniques are some things which are the worst thing that happen to a knee. So gentlemen and ladies, ACL reconstruction today is an established procedure because of the better implants, the better instruments, more graft options, and the fact that we are aware of the mechanical as well as the sensory issues involved over here. And there may come a time if we want to reduce donor morbidities that allografts may replace autografts in the future. Still, there are problems. Should we do it early in children? How should we do it in children? That's a problem. Women have to be made aware that they have more prone to injury, and if they're injured, they have to be rehabbed slightly differently. But it is still one of the most successful procedures in sports medicine. I thank you for your time, and I am willing to take any questions now. Okay, we've got some questions. Professor Narayana Reddy has asked us, is there an indication for non-operative treatment of ACLs? Well, Doc, in my hands, I think unless you are a professional athlete, I give this option to almost everybody. One of the reasons is that I just described that there are copers and non-copers, and we start off with a non-operative regimen for most people, making sure we do not allow them to re-injure their knee. So they get into a brace, they get into a rehab protocol, and they start feeling better. But if they are able to comply with that protocol, yes, you can do non-operative treatment. Additionally, in housewives, in sedentary people, with the proviso that they look after that knee, you can do that non-operative treatment. Second question is when to advise for MRI and ideal time for surgery. Well, an MRI is something which augments your diagnosis or makes clear your diagnosis of an ACL injury. The ACL injury in the acute phase is sometimes difficult to diagnose because of pain, because of swelling, and all ACL injuries are not isolated. So you could have chondral damage, you could have meniscus injuries. So yes, after you've rested the knee for a couple of days, it's not an acute emergency unless you have a vascular or a neural compromise. Settle the knee, then look at the MRI, because you're going to get a lot of swelling in that knee. You're going to see a lot of bone marrow edema in that knee, and you can also pick up associated injuries. So a couple of days down the line, an MRI, but remember, do a good quality MRI. These small 0.5T MRIs, sometimes they are not that clear, and you miss some of these small injuries. But start with a radiograph. The X-rays will give you so much knowledge. They will tell you whether there is a bony avulsion or not, and then you start with a radiograph and think of an MRI based on your clinical assessment. That's what you need to do about the MRI. Then what is the radiological landmark for appropriate tunnel placement? Well, Nishant, I don't use an intraoperative CM, but a radiological landmark you talk about millimeters. So if you want to use an intraoperative CM, you need to leave a couple of, for the femoral tunnel, you need to leave a couple of millimeters at the back to prevent blowout. And the tibial tunnel is you can have a straight, you can in about 10 degrees of extension, you make sure that the tibial tunnel exits posterior to the Blumensaat's line so that you don't have any impingement of the graft in full extension. Now, hi Prakash Varnagar, you said hi, so I say hi. And MS says, how to medically and symptomatically manage pain before taking the patient for ACL reconstruction. Good idea. Now, the first thing you must do for an ACL injury is assume that it is not an isolated ACL injury. So you compress them, you use lots of ice, and you brace them, because movement in the first few days will cause pain. If you talk to these guys, they are probably unable to bear weight on the first day. Many factors come into this, one of them being bone marrow edema, and could be associated cartilage or meniscus injury also. Nevertheless, in most of them, if you give them temporary immobilization, lots of ice and NSAIDs, pain will disappear in a few days. At that time, you need to start moving the knee, because by now you've got your diagnosis correct. You made sure there's no collateral ligament injury or there's no bony injury. It's an ACL with or without a meniscus kind of stuff. Then you start mobilizing the knee, because you need to make sure that the quads wasting doesn't happen and you regain the range of motion. Because by now you're deciding whether to operate or not to operate. You've got an MRI which tells you. And the pain, with appropriate orthopedic medical management, will go away in a few days. So I don't like these immobilizers for more than 2, 3, 4 days. After that, if you want to give them a brace, give them a proper brace which prevents tibial translation but allows range of motion. The Donjoy brace, the Osur brace, all these braces, some of the Tynoids, Indian companies are making them. Those are the best for them. What about weight bearing? I would say after a few days as tolerated. If you keep them off weight bearing, there is going to be a problem. But you only allow them weight bearing if you are sure there is no associated fracture. Dr. Baman Ojha from Cuttack, hi. He's asked why patients, even those who are not athletes, have quadriceps in ACL injuries. I am not so sure I understood that. Would you type in the question again? Are you talking about quadriceps wasting? But I'll wait for you to type the question again. Now, Raja says, is there any role of reinforcement of the residual stump with the graft, as the loose stump may cause any impingement? I believe you're talking about the so-called cyclops lesion. So you have to be very careful, because this residual stump could hypertrophy. If it hypertrophies, it will impinge against the notch and prevent full extension. So you have to be very careful what you leave behind. Do not leave too much floating tissue. Just leave enough which you know will adhere to the graft, and it will make sure you look at the knee in full extension and there is no impingement. So I do agree, if you leave too much of the ACL tissue, it can form a cyclops lesion and could give rise to loss of extension. Dr. Urvil from Ahmedabad, waiting for 10 to 14 days post-injury in ACL reconstruction, is it necessary? Well, sir, I try and talk to all my patients that there's a chance you may not need ACL surgery. I'm not an operator on 100%. So now early surgery is only required if you are playing for the national team. That the timeout would be a big disaster. Otherwise, what you need to do is you have to settle the hemarthrosis. You have to make sure that he gets a painless range of motion, and you have to ensure that the bone marrow edema doesn't give you a trouble. So I wait for not only 15 days, I wait for even more than 15, 16 days, because the incidence of arthropfibrosis and loss of terminal extension is significant. And of course, most patients who come to me who are not high-end athletes have not come to me for surgery, they come to me for an opinion. And they have not made up their mind that I want surgery. So as a surgeon, I would not advocate surgery to all of them. Although most of them, especially if they're young adults, would end up needing it. But I buy some time. We buy time to rehab the knee. We buy time to get good range of motion. We buy time for the acute phase reactions to subside. The knee becomes silent, it becomes quiescent. Patient gets comfort back. And we have a specialized trained physiotherapist who puts them on what we call as a prehab protocol, in which we work on the hamstrings and the quadriceps. Patient gets the confidence back in the knee. Shraddha from SRMC Chennai. Hi Shraddha. Any change in the protocols in BPT and hamstrings graft? Well, I don't know, because I routinely don't use hamstrings, but I don't think so. The reason is, initially we are only working on range of motion, but in both of them, the thing which wastes the most, which wastes the fastest, is the quadriceps. From your institute only, SRMC, you've just published a thesis in which you are saying that the hamstrings have a significant potential for regeneration. So you cannot do a hamstring strengthening protocol in these guys. One of the reasons why I go to BPT in these guys, because you've taken out the hamstrings. So personally speaking, for strength training, it would be slightly different. But for both of them, you work on the quads, and ultimately when the pain goes away, you work on strengthening the biceps in hamstrings graft. Dr. Amit Das from SCB Medical College, do you correct steep tibial slope in ACL revision? Well, we didn't talk about revision. and I won't go into that because probably many of the people here are postgraduates, and there's also a role of a high tibia osteotomy in various knees, but we won't talk about that right now. If you don't operate the ACL in a non-athlete, that's from Visakhapatnam, Dr. Loknath, can we estimate the degree of damage to the joint in future, and can we quantify and explain that? Yes, remember this, it's an important question. If you leave these ACLs and don't do anything to them, they will have multiple episodes of giving way. If they have that, they will cause secondary chondral and meniscus damage. So if you've allowed a patient to undergo non-operative therapy, he should come to you. And if he's giving way, he has to give up non-operative therapy and has to get reconstruction done. Even the results of ACL reconstruction are worse if a patient has come to you with 5, 7, 10 episodes of bleeding. That means if the delay in surgery is too long. They've already got secondary damage, they've got weak secondary restraints, so the ACL itself may not be able to give that much strength to the knee. So yes, non-operative treatment, don't misunderstand me, is only meant for patients who don't want it, one, and who are willing to comply with all the requirements of a non-operative treatment. I've got like these eyes. If I'm willing to wear glasses all my life, I don't need surgery for my eye. But my eye not got better. So the patient has to know his ACL is not going to heal. If he can get into an exercise protocol and he has low demands, many of them do well. But it should be made clear to him that if his knee gives way more than once, he must come back for ACL reconstruction. That is very, very clear. Tips and tricks to avoid tibial fixation method. That's for again Dr. Sivananda from Visakhapatnam. Any method to do tibial fixation without screw fixation? You can use endo buttons. You can use screws outside in the tibia. You can use a simple screw and tie it around them. But perhaps the best method of achieving stability is interference screws. There is no graft movement, because when you use distant fixation at the end of the tibial tunnel in the distal part, when you move the knee, you get what is called as the windshield wiper effect. The graft will move inside the tunnel, and then over a period of time you're not so sure about the graft incorporation because the tunnel is widening. So there are methods which will avoid screws, but they are probably not the best things which we've got going for us today. Dr. Shalin from Surat. Hi Shalin. The question is, why are thickness and shape of same diameter tibial and femoral drills different? The reason being, the femoral drill is an acorn drill. It has to only drill at the tip. You have to make sure you don't damage the PCL when you're doing it. Whereas when you're drilling in the tibia, it doesn't matter, there's nothing there, it's only bone. I just showed you in my slide that even if you're putting this acorn drill, don't rotate it till you are touching bone and gone beyond the PCL. That's the reason the drills are actually shaped differently, and because the function is different and the complications are different. Dr. Ashok, Visakhapatnam, it's a repeat question. How early should ACL repair be done? Can you specify the time? Well, I think I've answered this question early, but I am not an early repairer. Unless somebody is playing for the national soccer team whose time is important, whose money is important, early repair means arthrofibrosis and complications and poor rehab in the painful time. So we wait for a while. The ideal time is about 4 to 6 weeks when the knee is quiescent and the rehab has been done and some quadriceps training has been done. If you're planning to operate, don't leave it too late. The quadriceps wastes very fast. So 4 to 6 weeks with a quiescent knee is perhaps the best time for you to do it. Shobjit Taneja, when do we start knee bending in a single bundle reconstruct? Hi Shobjit, you're from Ahmedabad. We start bending the knee within a day. If you got good eyes and you got good stability, we start bending the knee to 90 degrees within 1 day. Only thing is, when we are doing extension, now it's something which is playing on our minds, we allow them active extension from 90 degrees to 45 degrees. Because from 45 to 0 degrees, presumably the quadriceps will cause some translation of the tibia. But remember, Once you've finished your ACL reconstruction, this graft should be snugly held. It should be tight and there should be no potential for movement. So it really doesn't matter. But my protocol, start to 90, bend as soon as possible, use lots of ice. 90 to 45, this range of movement is active. Quadriceps, hamstrings, quadriceps. Then passive movement to full extension. And when they are not exercising, we lock the brace in full extension to make sure they retain full extension. And within 3 weeks, they're even doing full active extension also. Dr. Prathan Amin, do you advocate the use of a tibial post over and above interference screw? I don't know. I don't think so. Unless I find that the interference screw is loose, then it's not supposed to be there at all. It should be a very snug fit. So if you're using a hamstring graft in a 8 mm tunnel, put in a 9 mm screw. So tibial post is only when you think your fixation is not very good. Again, Chaitanya for Surat, does tibial disc provide additional protection? Only if your interference screw is non-functional. The same question applies. Dr. Suresh Vishakhapatnam, role of peroneus longus tendon in ACL reconstruction. I've heard of it being done. I have never done it. And I don't think it's as strong as the other ones, and you have a fair decent length. But I do believe I know people who are using allografts. And some of them are even using autograft peroneal tendon. But I am a foot surgeon myself, so I'm not very happy in taking out the peroneus longus if it is not required to be done. Very limited experience with that. What are your views, Dr. Sarwar from Skims, Srinagar? What are your views regarding double bundle? I just told you in my slide, I think double bundle is phasing out. I say it is double the cost, double the trouble for half the advantage. So personally, I'm not a double bundle man, although Freddy Fu would kill me for that, but it's technically more demanding. So if you were to do a double bundle wrong, you are going to be much more trouble than having to err a little bit in a single bundle reconstruction. And the indications are also, if you got complex instabilities, yes, double bundles may slightly be better, but you have to have a lot of experience to get away with a double bundle, because the tunnel placements are important. The tunnel directions have to be different, because if you have them parallel, they can break through. Nowadays, people are doing double bundles through single tunnels. They've been shown to be as good as double bundles through double bundles, but as I say, no personal experience, and the literature says it's going the other way. In Dr. Suhit Shah, in ACL and PCL associated only, can only ACL reconstruction compensate for both injuries? No. If you got an ACL and PCL and you do an ACL injury, ACL reconstruction, the guy will actually feel worse. So you have to make sure. So it is ideal to do both of them. From Visakhapatnam said that when the graft length is more than requirement, redoing or is any physiotherapy helpful? I didn't quite understand the question, but let me be very clear about it. Many times if you follow the textbooks, in a bone patellar tendon or something, you will find that they say take a 10 mm graft. I don't think a 10 mm is required, 10 cm is required in India. We get away with 9. Secondly, the patellar tendon lengths can be different. So, couple of tricks. If I take an extra piece of bone from the tibia, from the upper part of the tibia along with the bone from there, reverse it and put this longer part into the femur, pulling it up, and then it's okay. But otherwise, if the graft length is long, in hamstrings it doesn't matter. But in bone patellar tendon, you probably have to shave off a bit of the bone and use a bigger or a thicker interference screw at the distal level. The physiotherapy does not depend upon graft length. The extent of physiotherapy allowed depends upon many factors. The most important being how solidly you have fixed the graft into bone. If you are dissatisfied, then you have not done a good job, because this fixation has to be strong to allow early physiotherapy, early range of motion exercises. So that's very, very important. I'm getting some more questions in. Iftikhar from GMC Srinagar, what is the ideal position of the femoral tunnel? Well, it's, I think I showed you a picture. You can't go too much to the back, otherwise you will have a blowout at the back. Remember, the knee is flexed. So the posterior is actually to this side. So you go up there leaving about a 1 to 2 millimeter bridge, not more than 1 millimeter bridge. Don't go that posterior that in flexion you impinge upon the PCL. So if you're too anterior, you will impinge in the front, in the intercondylar notch. If you go too posterior, you will impinge on the PCL in flexion. So you have these aiming devices, and they have a different offset, different aiming devices. So it depends. They give you an 8 or sometimes a 10 or a 6, and that means that depending upon the width or the diameter of the tunnel, that much posterior tunnel is left at the back. Sohail, what's your opinion regarding hamstring graft with a tibial attachment preservation? Well, I've read one study, and that was from Chandigarh, from the Government Medical College over here. They've taken the attachment over there and they've put it over there, but then they are using a double tendon graft, because unless you can't make it into a 4-strand graft. But seems reasonable, but it also I don't think we have a great advantage, because with the current methodology of fixation, you can get as good a fixation inside the tunnel as by leaving the insertion over here. Ibris, when is the graft the weakest after reconstruction, and should we advise the patient to take any precautions regarding this? Well, I think the graft is the strongest on day one. It's living tissue, it's the strongest. Over time, when the cells etc. die, it tends to become weaker, but it doesn't become that much weaker that you should not be taking any, you should be taking any extra precautions. The interference screw fixation is also very strong on the first day. Over time, you will get graft incorporation and it will become stronger. But if you are getting too much neovascularization in the graft, then you could have areas of weakness. But otherwise, I don't think that you will be calling when should the graft be, because as the muscles become stronger over time, they become more protective in nature. And the abnormal movements, the slides, the abnormal rotations will go away. So probably the abnormal movements and slides or the glides are there on the first day when the muscles are not firing in the right sequence. So that's the key point. But otherwise, it depends. If the diameter of the graft is good, the muscles are good, you really need some kind of big injury to damage the graft. What is the optimal intra-articular graft length and thickness? Well, most hamstrings have 7, a little more than 7. The length depends, by and large, it's about 40 most times, but it depends upon, or maybe less, 40 may be a bit too long, depends upon the position of the tibial and the femoral tunnels. If your tibial tunnels are too anterior, you'll get a longer graft, because you can't take the femoral tunnel too back posterior. Or if your femoral tunnel is too anterior, which is a bad thing anyway, you get a smaller and a vertical graft. So it depends upon the size of the knee. You usually have a 35 to 45 tibial tunnel and a 25 to 30 femoral tunnel. So that leaves you about 25 inside the knee. Choice of graft, again from Visakhapatnam, choice of graft in pediatric ACL reconstruction. That's a valid point, because in pediatric ACL reconstruction, we are scared about the epiphyseal plates. So firstly, if you're forced to do a ACL reconstruction in a child, we don't use bone. We only use soft tissue grafts, because bone would fuse the plate and you'll have a problem. So the hamstrings is perhaps much better. I don't think you should do a BPT in a child. If they are 14, 15, when you think the physis is going away and they're going to go into high contact or a high level sports activities, maybe so. But otherwise, soft tissue grafts. The old technique of Macintosh of using over the top techniques would avoid drilling tunnels into the femur, but it would make the graft non-anatomic. So the best thing for children is, see, you really don't, you get avulsions in children of 9, 10 years of age. It's only when they're 12, 13, 14 and they go into high-level sports that they start getting ACL injuries. So at that time, if you're forced to reconstruct, don't use bone patellar graft, use soft tissue grafts and use distant fixation so that you damage the part crossing the physial plate as little as possible. Any specific precautions to follow in patients with ACL reconstruction and inflammatory arthritis? I didn't understand what inflammatory arthritis means. Do you mean a patient who already had arthritis and got an ACL injury, or who got an infection or inflammation subsequently? If you get an infection or an inflammation post ACL reconstruction, you are also going to get arthrofibrosis. This knee will be painful. They will not do the rehab protocols properly, and if you think it's an infection, you go in and lavage the joint immediately. Get your cultures, lavage the joint, take out any extra synovium. Don't try and treat them medically unless it's a superficial infection and you have smaller problems over there. But you could end up losing the graft if there is significant inflammation and significant infection. What is your protocol in an acute IDK with hemarthrosis in an active young adult? Dr. Sandesh, the word IDK only means I don't know. So we don't use the word internal derangements of the knee, because you are supposed to know what is the derangement of the knee before you can prescribe any treatment. So it is actually using the word IDK has become a joke, because we mean I don't know. But with modern diagnostic ability, modern tests available including MRI, you know exactly what is happening. So any acute injury, you have to follow the Price protocol. That means you protect the part, you rest the part, you apply ice to it, you can give compression and you can elevate it. So the Price protocol is followed till the acute pain swelling subsides, and subsequently you follow everything exactly what I said as we said over here. Jeet Prachi Kandi, how to manage an intraference screw which is found intra-articularly post-operatively? I don't know what he means. Whether it's a loose screw which is lying in the joint, or it's a protruding screw which is lying in the joint. In both these scenarios, you need to revise the screw. If it's a loose screw which is sort of come out from the femur or is lying, it was not holding in the first place. So you need a bigger screw. You need to go in, take out the screw, arthroscopically retighten that graft and fix it. If it is protruding either in the femur or in the tibia, it's going to give you trouble. Because if it's protruding in the femur, the graft will bowstring along it in extension and flexion. So unless this is on the other side when there is no graft movement, it should either be completely inserted or it should be taken out and changed for the right size of screw. What is the next question? From Patna, Avinash, that's the last question. Kindly explain about the bungee and the wind Kaiser. It's the windshield wiper effect. So the windshield wiper effect is that you've got the graft fixed in the femur, and when you are moving like a wiper in the windscreen, this graft moves. And in the tibial tunnel, if it is not held properly, it will move differentially. It will move in the tunnel. And with this windshield wiper effect, the tibial tunnel can expand over time. And you can see this on x-rays when you follow them up for 9 months, 1 year, 2 years. So that means the incorporation will be a problem, and that's why we avoid distant fixation. If you got interference fixation, it will avoid this movement in the tibial tunnel, and the windshield wiper effect will be lost. Then folks, I'm going to call it a day. Thank you so much for attending this webinar. Goodbye, good luck, have a great weekend. Thank you very much.